In this video, we will see the restoration of a mutilated eyeball which was damaged due to injury by a metal wire. Now, this is the individual, a 25-year-old male who presented to us with a full chamber hyphema, a corneal laceration, and a uveal tissue prolapse. Now, these eyes have incision or the laceration which is very irregular, and the surgery is very difficult because suturing itself requires some tricky maneuvers. Now, this surgery is being done under topical anesthesia as the patient was very cooperative, and I have fast forwarded the video just to save time. The message is still there. Now, suturing requires that we use appropriate suture. Here we are using a 10-0 nylon suture which is thin enough and strong enough to hold the corneal laceration in place, and interrupted bites and sutures are best for this situation because the laceration is not a linear incised wound. It has got few its own nuances, and it may be having abnormal curvature. So as you proceed, first suture is to be put up at a point where you can easily identify the landmark so as to approximate the two correct points on the edges of the wound. And then as you proceed, you continue suturing them, and as the wound starts closing, you can reposit the tissue. It may be necessary to revise the sutures because initially the sutures are under great tension. So as the suturing is proceeded, the subsequent sutures take up the weight and the pressure, so that the initial sutures which was appearing tight will appear loose later on. So this can be revised at appropriate time. The purpose of suturing is to create a watertight seal so as not to allow any aqueous or any leakage of any fluid from inside the eye. The sutures have to be of adequate length, and there should be ideally a square formed by joining the two adjacent sutures. It may be kept a little more closer for having a better closure without causing too much of tissue compression. Any amount of excessive tissue compression is going to result into an abnormal curvature and a subsequent irregular astigmatism. But right now the priority is to suture properly so as to restore the anatomy of the anterior chamber. The knots are to be buried because these knots are going to cause a lot of irritation. So it's mandatory that knot should be always buried whenever corneal lacerations are repaired. Proceeding for removing the anterior chamber blood, making a self-sealing incision using a keratome 2.8, and then injecting intracameral lignocaine. So this will supplement the topical anesthesia and make the surgery and maneuvers in the anterior chamber less painful for the patient. Moving on to remove the liquefied portion of the blood using a Simcoe cannula, and once an edge of the clot has been identified by removing the liquefied portion, one can proceed to use a dialer. A viscoelastic is being injected to form the chamber, and a dialer is used to scrape off the coagulated blood from the surface of the iris. Care should be taken not to engage the iris, otherwise it will cause a tear. Carefully the edge, once it is identified, is pulled using a capsulorhexis forceps, and very gradually and slowly the clot is removed from the anterior chamber. Once it is removed, this is the picture at 1.5 months, where we can see the sutures, a cataract has formed, some amount of subluxation is there, and the chamber is well formed. After making a clear corneal incision, we are proceeding for removing the posterior synechia so as to free the capsule. The cortex or the cataract lens material is liquefied cortex only, so there is no nucleus, so no need to emulsified simple aspiration irrigation is going to work for this job. Once the bag has been emptied, it was clear that the zonular damage is also there, so as to stabilize the capsular bag, a CTR implantation was planned, which is implanted through the same main incision, and it is dialed into position. Once the leading part of the CTR or the capsular tension ring has gone into the bag, the trailing part is dialed using a dialer. This will keep the bag stretched and will stabilize the bag by using the or distributing the pressure among the remaining zonules. Implanting a monofocal hydrophobic single piece IOL in the bag Now this maneuver is going to restore the optical path of the light so as the patient can see. Anterior chamber is inflated using a air bubble, and the sutures which have been left behind are now removed because they have done their job. So this is a journey overall extending over a period of 4 months, when the corneal incision or the laceration has healed, left behind this opacity which is slightly peripheral, so it will not engage the central visual axis, and we expect some amount of visual recovery in this patient. The ultrasound which was done has revealed that it was a normal posterior segment, and now we can also have a look at the fundus which appeared normal to us. This is the first day post-op picture, and this is the picture at day 7 when the wound has healed, and we can see there is some amount of posterior capsular opacity which was subsequently removed using YAG laser. Thank you.